Stalin, sir, we are live now.
Yeah. Waiting for 1 minute for 5 o'clock.
Sure.
Ma'am, we are live and we are starting session.
Yes.
So very good evening, doctors. I'm Dr. Stalin on behalf of Shield Healthcare, welcoming you all for the Prayas webinar series on infertility. So topic for today's session is low AMH in poor responders. I welcome all the participants and I request them to post their queries, if any, in the chat box, so that we can have a short QA session at the end of this presentation. Now it's time to introduce our invited speaker for the day, Dr. Jyoti Banglawala ma'am. Madam has a very vast experience of 26 years in the field of obstetrics and gynecology. Madam is currently the secretary of Indoor OG Society. Madam is interested in ethical and medical legal aspects of obstetrics and gynecology, published many papers and conducted various educational awareness campaigns. Madam has held various positions in Foxy committees, and also Madam has held the position of member of IAC, member of Fetal Breast Committee, member of Practical Ethics Committee, and Madam has held the position of treasurer in AICOG 2022 Indo. And also Madam has received various awards to her credit, to say some few in like Nari Shakti Award from IMA, Indoor IMA Corona Warrior Award from Government of Madhya Pradesh, and recipient of Corona Warrior Award on 15th August of 2021 by Indoor Collector. So with this short introduction, I welcome you, ma'am. I'm handing the session to you for your presentation, ma'am. Eager to hear you. Thank you.
Thank you for the kind introduction, and good evening everyone who has joined this Prayas series of webinar. And we are presenting a very day-to-day topic for just revisiting these topics which we do in our day-to-day practice. A short brief about everything. So today is the low AMH and poor responder. So this is just a basic topic. Everyone were. So today's topic is low AMH and poor responders. And this is the very concerned topic for the infertility treatment by the gynecologist. And poor ovarian responses are the site.
Yeah, ma'am. Full screen is not posted here.
There is no full screen? Just a minute.
No, ma'am.
Now?
Yes, ma'am, it's fine now, ma'am. Yeah, ma'am. Please.
Okay. So low AMH in the poor responders. Our screen is not moving. Yes. And this is the concern of the infertility specialist everywhere when there is a poor ovarian responses. And that is the cause of the cycle cancellations, poor pregnancy rates, excessive ovarian responses, and risk of ovarian hyperstimulation syndrome, and high E2 detrimental to the outcome. Then the physiology of the ovarian responses, there is the follicular recruitment, then the selection of the dominant follicle by the body, follicular growth and estradiol synthesis, then endometrial proliferation, then follicular rupture, and then the luteal phase changes. Everybody knows this who do or do not do the infertility practice. So there is the evolution of OR test. Over the past 2 decades, a number of so-called ovarian tests have studied for their ability to predict outcome of IVF in terms of oocyte yield and occurrence of the pregnancy. Some of these tests have become part of the routine diagnostic procedure for infertility patients that will undergo assisted reproductive techniques. But ovarian reserve can be considered normal in conditions where stimulation with the use of exogenous gonadotropins will result in the development of at least 8 to 10 follicles and the retrieval of a corresponding number of healthy oocytes at follicle puncture. This study is by the Fasolution et al. In the 2000. An ovarian reserve is currently defined as the number and quality of the follicle left in the ovary at any given time. An accurate measure of the quantitative ovarian reserve would involve the counting of all follicles present in both ovaries as is done in the postpartum studies in 1952. For obvious reasons, in ovarian reserve testing, the true size of the follicle pool has not been used as the benchmark for the evaluation. And there are so many tests for the ovarian reserve, but most of the time we do the ultrasonography, whether it is the per abdomen or per vaginal or per rectum, and then the hormonal markers. Ultrasound markers are ovarian volume, antral follicle count, ovarian stroma vascularity, and in hormonal markers, AMH, FSH, inhibin, and estradiol. There are many other tests like CC test, GAST test, but it is not used in clinically, and in India it is not available in the many best places. Then what is AMH? AMH levels are indicative for the size of growing follicle pool and considered as the ovarian aging. AMH level decline with the age, hence decline in AMH level may be the earliest marker of the ovarian aging. Changes in serum AMH level occurs relatively early in the sequence of events associated with ovarian aging. There is strong correlation of serum AMH level with AFC. So whenever the AMH is going to low, the antral follicle count will be low. AMH is marker of ovarian responsiveness in women undergoing treatment for the infertility, and it helps to predict outcome of IVF procedures. This is the relation of AMH with other biochemical predictor. This is the chart. And the French endocrinologist Alfred Jost, he discovered anti-Mullerian hormone or Mullerian inhibin substance. It is a dimeric glycoprotein hormone belonging to the transforming growth factor beta family produced by the ovarian granulosa cell in females. There is the dynamic change in AMH levels and changes in the numbers of arterial follicle with age. You can see the highest age group, highest AMH level is at the age of 25 years. So from the age of 20 to 28, there is the AMH level are the highest in your life cycle, and then it declines. Model of AMH action in the ovary. Progressive stages of folliculogenesis are depicted. AMH is produced by the small growing primary and pre-antral follicles in the postnatal ovary and has two sites of action. It inhibits initial follicle recruitment and inhibits FSH-dependent growth and selection of prenatal, pre-antral and small antral follicles. So why AMH better for ovarian reserve? Because of gender differences in AMH concentration, it changes in circulating concentration with sexual development and its specificity for Sertoli and granulosa cells. Since AMH is produced continuously in the granulosa cell of small follicles during the menstrual cycle, it is superior to the episodically released gonadotropins and ovarian steroids as a marker of ovarian reserve. Furthermore, AMH concentrations are unaffected by pregnancy or use of oral or vaginal estrogen or progestin-based contraceptives. So that's why the gynecologists are always relying on the AMH counts. This is the normal range of AMH. Often in PCOS is high, then normal, then low normal range is 0.7 to 0.9 and low is 0.3 to 0.6 and very low is less than 0.3. Why AMH for ovarian reserve? It is superior than other markers. Paracrine control independent of HPO endocrine feedback correlates with AFC, FSH, inhibin B, and E2. Higher sensitivity and specificity than conventional markers. This is the cyclical recruitment. You can see what is the initial recruitment and what is the cyclical recruitment. And AMH is secreted by pre-antral and antral follicle, and you can see how it goes. So what are the factors modulating AMH levels in women? We all have to know that hardly influence AMH is the menstrual cycle, intra-individual variations, pregnancy, puerperium, obesity, gonadotropin releasing hormone agonist, smoking, alcohol consumption, stress, ovulation, hypogonadotropic hypogonadism, hyperprolactinemia, FSH administration. These all factors hardly influence AMH. And which factors decreases serum AMH? This is menopause, obesity, contraceptive hormones, pregnancy, primary ovarian insufficiency, premature ovarian failure, smoking, high TSH. Though they are saying it is hardly influence AMH, but in our day-to-day practice, we see smoking and alcohol consumption, it decreases the serum AMH. High TSH, low vitamin D3 level, autoimmune disease, lupus, Crohn's disease. High FSH level, ovarian chemotherapy, ovarian radiation, ovarian surgery, metformin therapy, gonadotropin releasing hormone agonist. And what are the factors increases serum AMH? PCOS, increased antral follicle count, increased LH level, hyperandrogenemia, ovarian hyperstimulation syndrome, insulin resistance, late onset congenital adrenal hyperplasia, granulosa cell tumor of ovary, gonadotropin releasing hormone agonist. So what is the significance of AMH in assisted reproductive technologies? In IVF program, numerous studies have explored the role of serum AMH and its measurement in predictive ovarian response to gonadotropin stimulation, individualizing treatment pathways to improve efficacy and safety, and lastly, predicting overall treatment success. Given the biological premise of AMH as a functional ovarian reserve marker, it is not surprising that it is these first two areas where AMH has made the greatest contribution. AMH and its relation to follicular development is now a key parameter measured by any patient seeking for ART. The relationship between AMH and the existing pool of antral and earlier stage follicles has led to AMH being used to gauge the size of women's ovarian reserve. This basis behind AMH has led it to being postulated as a factor that can not only help gauge the course of patient's ART cycle, but also how it should be planned. It has been well established that AMH levels, especially higher levels, are associated with significantly higher numbers of oocytes being retrieved and generally higher pregnancy rates. Studies have suggested a link between AMH and oocyte yield, and there is a link between AMH and ovarian response during an ART cycle. AMH was strongly correlated to oocyte yield in 365 conventional IVF cycles. When comparing AMH and age, AMH was a superior predictor of both oocyte yield and live birth compared with age. Overall, although AMH does serve a quantitative role in helping predict oocyte yield, the ability of this test to predict pregnancy and live birth rate is suggestive of a qualitative purpose too. So this is a very important marker for all the infertility cycles. AMH is used extensively to guide ART cycles. And the outcome, this is a study by the Brodin et al. He looked at the outcomes of 1,230 IVF intracytoplasmic sperm injection cycle outcome from the 892 patient and demonstrated that live birth rate increased long linearly up to 30.8% for an AMH 2.94 and greater. This trend remained significant even after adjusting for age and oocyte quality. There is another retrospective cohort study which showed that patient with an undetectable AMH had a 13.3-fold increased risk of cycle cancellation compared with an MH greater than 2.0 nanogram per ml. So the prediction of poor response and cycle cancellation, a proportion of women 2 to 30% undergoing COS experience poor response. The number of developed follicle and the number of retrieved oocytes are two of the most important criteria for defining poor response. The proposed number varies among different authors and ranges from less than 3 to less than 5 dominant follicles on the day of SCG and from less than 3 to less than 5 retrieved oocyte. More logically, poor response is generally considered to have occurred if the cycle is cancelled due to an inadequate ovarian response to stimulation. And what is the prediction of hyperresponse and ovarian hyperstimulation syndrome? The recognition of a dose-response relationship between AMH and ovarian response of FSH leads to hypothesis that hyperresponse to ovulation induction might result from high AMH. In this context, high basal AMH may be associated with the increased risk of developing OHSS. So, AMH measurement prior to gonadotropin stimulation could provide useful information to direct the application of mild pressure family stimulation protocol in order to avoid OHSS. So we have to always monitor the response, and we have to always monitor the AMH level so we can go for the stimulation protocol. Then this is the enteral follicle count. Then reflection of the primordial follicle pool, counting in longitudinal plane and then in the transverse plane. Various definition of AFC: 2 to 5 millimeter, or 2 to 8 millimeter, or 2 to 10 millimeter. But prediction of the poor response based on AFC is the same regardless of the definition used for the size of enteral follicle. Ultrasonographic assessment of the total number of enteral follicle measuring 2 to 9 millimeter is a reliable determinant of ovarian reserve. And the pool of enteral follicle comprises pre-enteral and early enteral follicle 0.2 to 2.0 mm that are largely gonadotropin independent. Small enteral follicles 1 to 6 mm selectable due to their responsiveness to gonadotropin, and larger enteral follicle more than 6 mm that are gonadotropin dependent. So the total enteral follicle count is made by counting the number of enteral follicles measuring 2 to 9 millimeter in both ovaries, and can be estimated using 2 or 3 dimensional ultrasound. This is the sonography based automated volume count, and automatically calculates the number and volume of hypoechoic structure in a volume database, and it can significantly reduce time for assessment and reporting, and from the calculated volume an average diameter can be calculated. And this is the most cost-effective single test sono AVC enteral follicle count. AFC versus hormonal marker. What is the difference? In AFC, result immediately available, moderate intra-observer variability, moderate intercycle variability, good correlation with number of oocyte obtained in IVF. And in hormonal markers, results are not immediately available. It takes time. No intra-observer variability, less intercycle variability, good correlation with number of oocytes obtained in IVF. So if you want immediate result, then the AFC is the good test. And if you want to wait for 2 or 3 days, then you can go for the hormonal markers. Prediction of oocyte quality. The quality of an embryo is dependent on the quality of oocyte used to produce it. AMH has been extensively assessed as a method to gauge the ability to extract intact oocyte that can lead to viable pregnancy. And this is the study Abner et al. He performed an in-depth study of AMH level and its correlation with oocyte quality, and reported that oocytes obtained from the patient with an intermediate AMH level between 1.6 and 2.5 had the best morphology. So what is the prediction of embryoploidy? The chromosomal content within an embryo has direct correlation with the ART outcome. Compared with the patient with an AMH greater than 1 nanogram per ml, patient with a lower AMH had significantly higher percentage of aneuploid embryos. What are the miscarriages rate in this? As AMH production is considered to be a facet of a normally functioning and viable ovarian follicle, attempts have been made to determine if the quality has any impact on the course of pregnancy. The women with AMH of less than or equal 0.4 nanogram per ml miscarried more than twice as often as women with AMH 1.0 or greater. A recent cohort study showed that the risk of miscarriages increased with the decreasing AMH. And that's why AMH is the most abused hormonal test. Everyone, even after the just 6 or 7 months of the marriage, the normal women come to us, we go straight away for the AMH. Do your AMH. AMH has a substantial inverse correlation with the risk of miscarriages, which suggests that AMH production can give qualitative information on the quality of oocytes and resultant embryos. AMH to predict ovarian responsiveness. It correlates with number of oocyte retrieved. Predictive value better than FSH, inhibin B and E2. Predictive value equal to AFC. AMH lower than 1, higher chances of cycle cancellation. AMH more than 4, high risk of ovarian stimulation syndrome, ovarian hyperstimulation syndrome. So What is the significance of low AMH before IVF cycles? For women with low AMH level, either cycle cancellation or poor response may be anticipated. So couple would need to accept protracted treatment programs and should be informed that not every cycle may result in embryo transfer and that it is highly probable that the chance of success may be reduced. Counseling and management of this group of patients is difficult for several reasons. First of all, accuracy of testing for poor responders appears to be better than for the prediction of pregnancy. But it is not fully reliable since a false positive rate of 10 to 20% can be always expected. This indicates that AMH measurement, similarly to the ovarian reserve markers, should not be used to exclude couples from IVF. What are the management? Regarding treatment, it is still not clear whether the individualization of the therapy may improve outcome. Indeed, although high doses of gonadotropin are widely administered to poor responder and to patients with the anticipated poor response, result reported in literature have been controversial. There are so many trials, they have shown little or no benefit. And similarly, it is not clear what kind of GnRH analog, either agonist or antagonist, may be more suitable for the pituitary suppression in these patients. In poor responders, how to manage? So we have to modify stimulation protocol. We have to add the adjuvant therapy. Then the conventional agonist protocol, dampening of ovarian response to gonadotropin stimulation. Then there is the mini dose protocol, there is the stop protocol, there is the short or ultra short or flare protocol, and there is the micro dose flare protocol. So in modified stimulation protocol, antagonist protocol, it decreases stimulation duration, fewer cancellation, and lesser gonadotropins. In adjuvant therapy, there must be growth hormone, androgens, soft protocols, RLH, L-arginine, steroids, and aspirin, and COC pill, estradiol. In growth hormones, there is the potentiate effect of FSH. Previous poor responders have proven benefit. It is costly, not widely available, and no consensus on dose or the route. Case control design 128 to 81, 2-unit subcutaneous growth hormone, more M2 oocytes, higher E2 levels, and pregnancy rate. In androgen DHES, essential pro-hormone in follicular steroidogenesis improves the ovarian micromelia, micronized DHES 25 mg TID for 4 months, improves pregnancy rates and reduces miscarriages rates. In LH plays a role in follicular development from D8 75 to 150 international unit, beneficial in a subset of more than 35 years age, previous POR, antagonist cycles, improves pregnancy rates. And in treatment, is there an ideal protocol? No, there is really no ideal protocol, and there is no really efficient treatment that could solve the problem of poor responders. The current question is still, which is the ideal protocol for patient defined as poor responders? And it is confirmed that the increase of FSH starting dose does not result in the higher pregnancy rates. It is found no differences between the starting dose of 300 unit, 450 unit, and 600 unit for gonadotropins in terms of retrieved oocytes, number of embryos obtained, and pregnancy rates. Maximal dosing currently set at 450 of FSH should be started as early in the cycle as possible. The dose may then be reduced once adequate response has been established. So now HMG versus recombinant FSH. Recombinant FSH was introduced in the mid-1990s and was initially touted to improve stimulation and pregnancy rates when compared with the already available equivalent dose of HMG. More recent trials have suggested that HMG may have advantages for poor responders undergoing IVF, although the data are limited. Mixed protocol of FSH and HMG have become popular to provide both a high FSH dose as well as some LH activity. The role of LH in stimulation protocol in the poor responders, is available as both a recombinant LH and in the standard urinary HMG, which contain 1:1 ratio of FSH and LH activity. Additional LH activity during stimulation for IVF can be obtained with 2 doses of urinary or recombinant HCG. LH activity has been postulated to the beneficial during early follicular recruitment by increasing FSH receptors, as well as maintaining follicular development during the later follicular maturation by maintaining steroid precursors. There are so many articles, they have looked at the role of LH, both recombinant as well as the mixed protocol with HMG. One reviewer has suggested that HMG, due to its LH activity, slightly increases the pregnancy rate in IVF when compared to the recombinant FSH alone. So always the mixed protocol is better in our practice. In GnRH analog, in poor ovarian reserve, the option could be to decrease the length of suppression by decreasing the duration of GnRH agonist use short and ultra short, mini and microdose flare-up regimes. Then what is the microdose flare protocol? It has been shown that a single dose of 25 to 50 nanogram of GnRH agonist given on the cycle, day 2, can increase both FSH and LH levels. The protocols utilizing minimal dose of GnRH agonist, such as 20 to 50 microgram twice daily for 2 days at the beginning of the cycle, this is the microdose flare protocol, are usually combined with the OCP pre-treatment in the cycle prior to COH to prevent corpus luteum rescue. In GnRH antagonist, improvement of the patient compliance, decreased number of days of stimulation and the amount of gonadotropin administration, reduction of the ovarian hyperstimulation syndrome. GnRH antagonists are not administration during the stage of follicular recruitment, and thus suppression of the endogenous gonadotropin secretion is not present at that time. So most protocol comments GnRH agonist when the mean diameter of lead follicle reaches 14 mm and continue daily until human chorionic gonadotropin administration. Suitable protocol for the poor responders is GnRH antagonist plus gonadotropins, and the reason for that is GnRH antagonist in the mid-late follicular phase during ovarian stimulation, it prevents the premature LH surge while not causing suppression in the early follicular phase. It obtains more natural follicular recruitment without any inhibitory effect and possibly induced by the GnRH agonist. So conclusion for this is serum AMH level decreases with age in women and hence marker for ovarian aging. Serum levels of AMH correlate strongly with the number of antral follicle, suggesting that AMH level reflect the size of the primordial follicle pool. Assessment of the ovarian reserve is particularly important in the IVF clinic, where AMH may be useful as a predictor of poor responders. Since a considerable proportion of subfertility is due to postponement of childbearing, measurement of AMH levels to assess the ovarian reserve may also be interesting in women in general. The elevated levels of AMH in these women strongly suggest that serum AMH level may also be used in the diagnosis of PCOS. And AMH levels are strongly correlated with the size of the follicle pool. Because of the lack of cycle variation, serum levels of AMH are a good candidate for the inclusion in standard diagnostic procedure to assess other ovarian dysfunction like the premature ovarian failure. And AFC is very much important factor for successful ART outcome. Thank you. And at the outset, I want to say the AMH and AFC both combined can give you the more diagnosis of value. Only AMH can't do anything. Only AFC can't do anything. So every cycle, you have to individualize every cycle. There is not a standard protocol for us, every patient. You have to go as per patient's AMH, AFC, other hormones, her age, her social background, her everything you have to keep in mind, and then use what protocol you want to use in the poor responders. Thank you. Thank you very much.
Thank you, ma'am. Thank you very much for that detailed presentation, ma'am. It's always an honor to hear you, ma'am. Ma'am, let me wait for 1 or 2 minutes for the participants to post their queries, ma'am. If there is any queries, then I will read it for you, ma'am.
Yes.
Participants, it's the time it's open for you. You can just post your queries.
Yes.
Ma'am, I have a question. Whether this AMH level fluctuate in every cycle, ma'am, each cycles.
No. AMH, in our slide, we have already shown that menstruation, pregnancy, everything, it does hardly matters. AMH level is constant level.
Ma'am, and what level of AMH is too low for natural conception, ma'am?
0.2.
0.2.
Yes. But in the many patients, we see many patients with the poor AMH, means the low AMH level, and they conceive naturally. So nowadays there are actually we are talking about the ART cycles, so we are stressing upon the AMH, but AMH is the most abused investigation protocol for everyone. AMH, thyroid, vitamin D, we all are writing this like a multivitamin tablets, but sometimes we say to the patient, oh, your AMH so low, go for the ART cycle. No, it is not necessary. Every low AMH patient have to go for the ART cycle. Many of them are becoming pregnant naturally also. If your dominant follicle is good in quality or size, everything, then the patient can be pregnant naturally also.
Okay, ma'am. And ma'am, one more question, ma'am. Whether this ovarian cyst will affect the AMH levels?
Ovarian cyst? No.
Whether any ovarian cyst will affect the AMH levels?
Yes, the ovarian, if the ovarian cyst excretes the hormones, the most of the time the AMH levels can go high.
And ma'am, one more question. Is there any natural way to improve these AMH levels, ma'am?
No.
Yeah, ma'am, there are a few studies.
Just to this is for the PCOD patients, to just for the lifestyle modification. AMH levels not go high, but at least it will not decrease so more. So there are sometimes gynecologists say to for the lifestyle modification in the PCOS patient, taking good vitamin D, going for the exercise and everything, and stop the smoking and alcohol. So even if the AMH level is low, the pregnancy outcome will be the better if you follow the certain protocol.
Okay, ma'am. And ma'am, in few patients, the AFC levels are normal and this AMH low levels are low, ma'am. So what would be your suggestion for those patients, ma'am?
If the AMH is low and AFC normal.
Yeah, ma'am.
Antral follicle count may be normal, but AMH hormone may be low. So you have to go for the ART procedure. Na?
Okay, ma'am.
Antral follicle count is the fixed count. AFC is the fixed whole life. It is the fixed count.
Okay.
But the AMH will go high in the 25 to 30 years, and then it will decline.
And there are patients with the age of 21, 23 also they're having nowadays, they're having very low
then
AMH.
we have to go for the PCOS and thyroid dysfunction. No, all other hormones, we have to investigate them.
Okay, ma'am. Thank you, ma'am. Thank you for addressing all those queries.
Thank you. And thank you very much, all the listeners. And thank you very much, the Shield Healthcare, for giving us this opportunity to connect with all our delegates. And we will see you next time. Thank you.
Yeah, ma'am. Thank you, ma'am. Please do support us in the webinars in coming days also, ma'am.
Yes, thank
it's
you.
Always an honor to hear you, ma'am. Thank you, ma'am. Thank you for being with us. So thank you for participation. Let's see in the next month.
Next month we will do something for just like a diet or exercise or something, a basic.
Sure.
We'll see some basic pregnancy or the vomiting or some basic topic we will choose.
Thank you, ma'am. Thank you very much.
Yeah.